Thank you, Miloš, and hello everybody. Good morning, good afternoon, good evening, wherever you are in the world. Bring you good wishes from Manchester in the United Kingdom, and a special hello to anybody who has graduated from our institution over the past 30 years when I've been there. It's a great pleasure to be with you today. We're going to be talking about COVID-19 disease and the implications from that disease for us in contact lens practice, and what a strange, fascinating, scary, weird time it is to be working at the moment. This is unprecedented, I'm sure. As Miloš said, I work at the University of Manchester. Here are my disclosures. I run a research group at the university. We're very fortunate to receive funds from many contact lens companies to support our work, and we appreciate that. This talk itself is sponsored by Johnson & Johnson. Much of the information I'll be covering this afternoon actually is in a paper that we have just published. This was published just a couple of days ago on April the 6th, a paper led by Lyndon Jones and Karen Walsh, who did a remarkable job in leading this team of authors to get this paper out to cover the main issues at the moment. This is an open access paper. It is freely available. It's still, as of today, actually sort of an uncorrected format, but it is available. But if you search for COVID-19 contact lenses, I'm sure you'll find this, this paper, but maybe just give it a day or two till the full corrected publication is released. But I want to acknowledge much of the work of my co-authors from this. And in many ways, this paper is a good example of a lot of the recent information that is becoming available on this topic. And now more than ever, as contact lens practitioners, it's important for us to keep in touch with the literature, not just, you know, believe what we see on random websites that pop up, but to look at the refereed literature. A lot of this stuff is getting published very quickly at the moment. The publishers are doing a great job in making it freely available in many instances. So do keep an eye out for the literature in this area. What do we know? What do we know about severe acute respiratory syndrome coronavirus 2? This is the new virus that is sweeping around the world. And when you look at the time course of what's happened recently, it's incredible how things have changed. In January and February, really through February, this was just a Chinese problem. But once we get into March, we see this incredible growth in multiple countries around the world. So very little was happening as little as 5 or 6 weeks ago, and here we are today. These data from April the 8th reporting that there are about 1.4 cases of disease related to this virus. The disease, of course, is coronavirus disease 2019, which is being shortened everywhere to COVID-19. It's now caused the deaths of over 81,000 people. So it's an incredible issue, and maybe something the world has not faced for 100 years. So a little bit on coronaviruses. I think this is important. Actually, some of this information is directly relevant to us as contact lens practitioners. It turns out there are 40 coronaviruses which have been named by the International Committee for Taxonomy of Viruses. Most of these affect animals only, in particular bats. There are 7 strains that affect humans. Now, 4 of these strains we've never heard of because they've been around for ages. They move freely around the world and produce mild symptoms like those of the common cold. But of course, over the past 20 years, we have heard more and more about coronaviruses. Firstly, the first SARS coronavirus, 2003, that moved around the world. About 8 years ago, we had the MERS, the Middle East Respiratory Syndrome coronavirus. And of course, we now have the SARS coronavirus 2 that is moving across the world so quickly. The structure of this virus actually also is relevant to us as contact lens practitioners. Now, like any virus, it contains RNA, which is surrounded by a protein shell. This is the nucleocapsid, and that is surrounded by a further shell, if you like, a lipid bilayer envelope. Now, from this envelope become a number of, I think, 3 different sorts of proteins. These are called spike proteins. They have one end that's anchored in this envelope, and then the other end kind of protrudes out, and it creates this rather elegant image, as you can see on the top. That's an electron micrograph, and the image below there is a schematic diagram. But these ends of these proteins that come out from the envelope create this crown, or this corona. Now, one of these proteins has a particular affinity for an enzyme that is present on the surface of the cells of many human tissues, the angiotensin converting enzyme 2, or ACE2. So this enzyme is on the surface of lots of cells in the human body. One of the proteins from the virus is attracted to this, and this allows the virus to actually invade and replicate within the cell, and is the reason why it is particularly harmful to us. It turns out that the affinity of this virus is greater than the first SARS virus, and this is why it appears to be transmitted much more readily. As a consequence of this, particular in organs like the lung, the lung is particularly susceptible to infection with this particular virus. Well, there is a local immune response. It is an overreaction of the immune response of the tissue. We get local hyperinflammation, and part of this sometimes gets the term of a cytokine storm, this massive inflammatory reaction that ultimately is responsible potentially for the death of the patient. One interesting characteristic that may apply to some of our patients is that those taking ACE inhibitors, typically for hypertension, appear to be more at risk of infection with this virus. And that is because people who take ACE inhibitors appear to have a greater level of the ACE2 enzyme on some of their cells. And so, if you like, there is more of a target for the virus to attack. It's unclear, interestingly, that how much how much of this enzyme is present in the cells at the ocular surface. It appears perhaps not much, but some of that information is not clear. And as we all know by now, the virus can be transmitted through the air, through sort of coughing or sneezing, by direct touching, shaking hands, something like that, or by indirect touching. Somebody has touched a handle, and then later on you touch it, and then gets onto your hands, onto your face, perhaps into your mouth, and then to the lungs. So, what do we know about the tear film and contact lens wearers and the potential for this virus to be problematic for our patients, for our contact lens wearers? It seems that it is very unusual for this virus to be present in the tear film. Two very recent reports, one from Zia et al., reporting that out of 30 patients with active COVID-19 disease, only one patient had the virus isolated in their tear film. And a more recent paper, still only in proof stage, out of Singapore, found that in 17 patients with this disease, none of them had this virus in the tear film. So overall, we have some confidence that it is not often present in the tear film, even in patients with COVID-19 disease. This gives us, I think, some assurance that there is perhaps no direct relationship between the disease and contact lens use. The Singapore paper concludes, for example, that this study suggests that the risk of transmission with the virus through the tears appears to be low. There have been reports on some websites that different materials appear to attract or bind this virus differently. And I think that the information here is not strong. I don't think we have clear evidence that different contact lens materials bind different levels of this virus. So I think we should be, at the moment, quite skeptical about that information. We also have quite limited information about the performance of different contact lens solutions. Certainly nobody's looked directly at this new virus, the SARS coronavirus 2, and the current contact lens solutions. Previous data looking at contact lens solutions with viruses is not very clear, quite equivocal. But I am interested in a report from about 10 years ago that suggests that rubbing and rinsing of contact lenses is something that's particularly useful to remove viruses from the contact lens surface. So I think now is the time to emphasize that step. And we know from this lipid bilayer that surrounds the virus that it is potentially susceptible to surfactant cleaning, which of course breaks up lipids. And so these have always been important steps, but right now, surfactant cleaning, rubbing and rinsing is perhaps more important than ever for our contact lens wearers. Now, some people might say, oh, well, it's a bit too, how can we be certain one way or the other about this? And it's certainly very early. We don't know too much about infection rates. I think if this was a particular problem for contact lens wearers, we would know this by now. That would have come out in the data, and I don't think we're seeing that. But all previous examinations of the relationship between viruses and contact lens wear suggest that there's no clear relationship between viral ocular disease and contact lens wear. And sure, this virus is different. It's of a different form, and we can't necessarily draw a direct line between this new virus and herpes simplex virus or other sorts of viruses. But for now, it's kind of the best we have. And we can, I think, be confident that this should not be a major issue. Spectacles perhaps have been mooted as being useful at this time. And I think contact lens wearers, especially those who are locked down or working from home, they maybe have less of a need for their contact lenses at this time. They might be wearing their spectacles more. That's okay. I think it would not be appropriate, though, to consider spectacles as a good protective device against this virus. Spectacles are certainly not generally considered to be adequate for eye protection. So we shouldn't give our patients sort of a false belief that they will be a good sort of physical barrier against this virus. And we should also remember that we're trying not to touch our faces at this time. Spectacles will repeatedly, for presbyopes, perhaps with reading glasses, go on and off the face all day. The virus can exist on hard plastic and other materials, perhaps for a number of days. And so we should also be advising our spectacle wearers to wash and dry their spectacles before they're put on. So we shouldn't forget that this also can affect our spectacle wearers and the advice we give to them, as well as our contact lens wearers. What are the professional bodies and others saying? In general, they are saying it still remains safe to wear contact lenses in the normal way, provided we remind our patients about the key steps for contact lens use. Some of the professional bodies now also talking about the appropriate safety systems for examining contact lens patients. A recent joint statement here from the UK, from both the College of Optometrists and the Royal College of Ophthalmologists, suggesting that at this time, even with asymptomatic patients, that face masks should be used for any procedure within 2 meters. And of course, that would involve just about all contact lens, I think all contact lens examinations, use of slit lamps, and also there's a recommendation from these groups to wear to use a plastic breath shield on slit lamps at this moment. It's also time, I think, to think out the box a little bit, think laterally about how we're going to communicate with our patients, what technology can we use, and certainly I know of a number of cases local here of practitioners using video examination of patients, sort of, if you like, a telemedicine type of approach to it, do as much of that is possible before perhaps considering a face-to-face examination. There is some useful advice available on the internet from trade groups here, from Euron Contact, which is the European trade body for contact lens manufacturers, advising us both on these quite attractive flashcards, which are available for download, about how we might have to reconsider some aspects of our contact lens practice in terms of personal protection, hand sanitization and other things. And then a card that's used for our patients, reminding them that whilst contact lens wear remains safe, there are some important steps that they should adopt. So I'd recommend these flashcards. They're available in multiple languages through the Euron Contact website, euroncontact.org. And so much of this information is brand new. It's coming at us all the time. Our paper was published 3 days ago. This information from the United States Centers for Disease Control and Prevention, their advice launched today, at least in the UK. In UK time, it came out today. A very important body advising people across the United States. And also we need to look at this internationally as well. The CDC recommends or suggests that there's no evidence to suggest that contact lens wearers are more at risk from acquiring COVID-19. Pretty much agreeing with what we said in our paper published 3 days ago, but also in agreement is that contact lens wearers, particularly at this time, should practice safe contact lens wear. This is important for 2 reasons. Firstly, a lot of people are at home in isolation. You know, they're not really supposed to leave the house, so they don't want to be leaving the house for clinical care. if they get some sort of problem. Also, healthcare systems are stretched at the moment. And so we need to do everything we can to keep our contact lens wearers safe. And I'm sure all of you are doing this around the world. But they say it's okay to continue to wear contact lenses. The information about solutions is a bit more equivocal. They confirm that they would expect peroxide solutions to be effective at killing the virus that causes COVID-19 disease. They say there's not really much information on multi-purpose solutions at the moment. And I would agree with that. We've got no direct evidence, but for the reasons that I suggested earlier on, I think at the moment, continuing use of multi-purpose solutions should be okay until we find out more. And maybe some of this work is going on at the moment. So some important messages there from the CDC. Now, Miloš, over to you, I think, at this point. I think we have a question to ask our big audience around the world, please. Here is the question. We're interested to find out what you are doing at the moment. Those of you who are in contact lens practice. I guess if you're not really working in contact lens practice, maybe don't offer an answer, but there are five available options here. Are you offering no services at the moment? You're sort of essentially closed. Number two, you're offering sort of phone or urgent or emergency appointments over the phone. Or maybe number three, you're offering emergency appointments, maybe potentially face-to-face. Number four, offering emergency eye care appointments only. And number five, you're offering everything. You're sort of fully open, including routine assessments. Please select one of those answers, and we'll just give 10 seconds, please, Miloš, for this. We want to keep moving here, keep the momentum going. So maybe we can have a look at the answers at the moment, Miloš. Okay, pretty split. I will say that almost nobody is offering full routine assessments, only 4%. 30% of the population or of our respondents are essentially closed, it would seem, and then the remaining, sort of a similar split between the remaining three options. Interesting. Thank you, Miloš. Let's move on with the presentation. What are the concerns we have? I would say a big concern that I have at the moment is not around contact lens infection from COVID-19, making infection more likely or making contact lens wearers more likely to get COVID-19 disease. I would be more concerned about healthcare systems being stretched. Here are some data from around the world, and we see that it perhaps looks like in many parts of the world, we're seeing something like the peak of this disease. Maybe Italy is perhaps a little bit beyond the peak, maybe hopefully moving there, maybe Spain as well. In the UK, not as clear. We seem to be a couple of weeks behind Italy, maybe we're somewhere near our peak. Now, we know that with a lot of patients needing care for COVID-19 disease, that healthcare systems are stretched. In ophthalmology in the UK, we know that some ophthalmologists are being removed from their ophthalmology duties to COVID-19 related duties. Here is a blog published a few days ago by a training ophthalmologist in London. Not doing ophthalmology anymore, but looking after patients with this disease. So healthcare systems are being stretched. And for both that reason and the fact that our patients or wearers cannot leave home very readily, we need to make sure that they're safe in their contact lenses. I'd encourage everybody to be prepared. Don't wait for one of your patients to have a problem and then think, what am I going to do about this? You know, consider this now. What if you get contacted through email or telephone somehow that you've got a patient who's having a problem? What are you going to do? Maybe it's not within your capability to treat that problem. Well, think about what is available locally to you. Can you refer these patients to somebody else? Now, exactly how this will operate will differ from country to country. Healthcare services around ophthalmology or optometry do tend to differ quite readily. But what can you do? What will you do in that scenario? Can you limit the impact on the more general healthcare services? And even this is changing. Even this information is changing. A very recent paper, just again published a few days ago in the UK, showing that therapeutically licensed optometrists are doing a very similar job to senior ophthalmologists with urgent cases generally across eye care in this country. So if you're in the UK, do you have an IP qualified optometrist you could refer to? And in other countries, have a similar think and decide what you would do. And things are going to be different. I'm very grateful to a colleague, Kaya Patel, in the UK, in Northampton, probably 150 miles south of where I am near Manchester. An example here of a patient he saw just last week. He is under lockdown. He's only offering emergency treatments, but he got an email early one morning from a patient complaining of a painful red eye. So he did something different. He triaged over the telephone, not something he would normally do. He phoned the patient, was happy that she didn't seem to be symptomatic of COVID-19 disease, and agreed to see her very quickly, within the hour, in fact. Confirmed a corneal ulcer, diagnosis of microbial keratitis. The two upper pictures here are the fluorescein and white light image that you can see here. He prescribed cyclopentolate and an antibiotic, called her up the next day, things were getting better, saw her 4 days later, much happier, things on the mend. That's what the lower pictures are. So here's a different style of his practice. He had to think laterally. He had his telephone triaging system, quickly saw her very carefully, very quickly, but was able to treat her, and there was no need. I know he was keen not to put any extra pressure on the local general healthcare services, so he could treat this himself. So we've got to think increasingly in this way. Here's some more brand new information. Just today, we've launched at my research group, Eurolens Research, a survey of what existing contact lens wearers are doing. This data are as of about 3 hours ago. We got in touch with hundreds of patients. At that time, 60 had responded. 7 reported that they were sort of living normal life. They probably have jobs that allow them to be at work, you know, key important jobs. But 53 reported they are, you know, working from home or in isolation and lockdown. I asked them what's happening with their contact lens use. 3/4 report that they're using their contact lens where contact lenses less, and about 1/4 about the same, with one patient actually using the lenses more. I was fascinated to find out why they're using their contact lenses less, those that reported doing so. Was it because of the fear of infection? Was it for some other reason? And what we found is that in 3/4 of those reporting they're using their contact lenses less, it's simply because they're at home. They've got less need for their contact lenses. Normally they put their contact lens in to look good, to feel good when they're out and about, they're going to work. Well, now they're at home, there's perhaps less of a need for it. And I can understand that. Only 7%, I think that was only 2 respondents, reported that they were concerned about touching their face when they put their contact lenses in. Now, I think we can give them some assurance that, you know, they're going to be washing their hands and do all that. That should be a perfectly reasonable thing to do. But that was the concern that they had, and that seems, I can understand that. And then the rest, sort of a range of other reasons, including to save a bit of money. And 2 or 3 people, I think 3 respondents were saying they're a bit concerned about ongoing supply of contact lenses, and they were sort of saving their lenses. So we don't see great fear of infection, either contact lens related infection or causing COVID-19 from contact lens use. And I think that's good. I think that's positive. Maybe suggests things could get back to normal fairly quickly, hopefully, when the world gets back to normal. So this issue of stopping people needing extra healthcare treatment, keeping them safe, what are we talking about? Well, we're talking largely about this sort of response to contact lens use, this range of responses which we call corneal infiltrative events, which is a term that is synonymous with keratitis. These are all forms of that sort of response, all characterized by white blood cells that infiltrate into the cornea. And in all of these pictures and videos, you can see the presence of white blood cells. They've come in to protect the eye from infection or as part of the inflammatory process. Deborah Sweeney, nearly 20 years, described this family of events, some of which, as on the left here, are asymptomatic, non-significant, but they go all the way through to the slide on the right, microbial keratitis, a frank infection during contact lens wear. Well, it's this family, shown in the red square, that I want to talk about today. These are the symptomatic forms of CIEs, or corneal infiltrative events. These are the forms that might require a patient to seek clinical care of some type. This is what we want to minimize in particular at the moment. How do these happen? Well, there's one common denominator, that is the presence of bacteria. Bacteria largely is, bacteria are thought to be in the etiology of just about all of these responses. Here's one example, the contact lens peripheral ulcer. Thought to be a response to the entrapment of some bacteria, probably Staphylococcus aureus, trapped between the contact lens and the corneal epithelium. The bacterium is not invading and infecting the cornea, but it is causing an inflammatory response because during its life cycle, it releases toxins into its environment. Some of these will reach the cornea. Some of the protective inflammatory cells in the cornea, dendritic cells and other types of cells, will perhaps detect these toxins. They will signal to the local vasculature through cytokines, chemical messengers, to kick off an inflammatory response. And part of that is to see the ingress of white blood cells moving into the cornea to, if you like, sort out the problem. Now, as part of this particular response, for reasons which I think are not well understood, there's also a breakdown of the epithelial tissue. We lose some tissue, and that's an ulcer. So this has been caused by the presence of a bacterium, but it's not directly related to an infection. What does this look like on a slit lamp? Well, if we put fluorescein in the tear film, we're going to see two things. Firstly, under white light, we're going to see those white blood cells, that cluster of white blood cells called corneal infiltrate. If we put fluorescein in, it's going to fill in the hole, it's going to fill in that ulcer, and we're going to see that as well on the slit lamp. So that's a CLPU, often symptomatic, and maybe something people will be seeking attention for as part of their contact lens use. A more severe response is microbial keratitis. A range of microorganisms can cause this, as I think you will know, one of which is Pseudomonas aeruginosa, and I'd refer everybody to the incredible work of Suzanne Fleissig if you want to know more about Pseudomonas aeruginosa during contact lens wear. Well, this particular bacterium will invade and infect the cornea, moving right through the epithelium into the stroma, potentially. There'll be a massive inflammatory response, big ulcer loss potentially, and of course this will look very nasty on a slit lamp. But once again, the presence of bacteria responsible for this. So, what are the main contact lens related risk factors for this range of responses? Let's look first at microbial keratitis, the more significant of these responses. The best data, we need to go back 12 years for this. Fiona Stapleton's remarkable work across Australia, trying to measure the incidence of microbial keratitis in contact lens use. And we see that compared with use of daily wear lens, in particular daily disposables, people sleeping in lenses have about a 10 times greater risk. Now, overall, the risk is still small, but it's 10 times greater than if they're using the lenses on a daily wear basis. Does this mean we should never fit extended wear lenses? No, there will be some cases where the benefits of extended wear outweigh the risks of getting an infection, but you know, it is an important risk factor that we need to be aware of, and certainly at the current time, something we should be conscious of. Now, what about more generally this whole family of CIEs? What are the contact lens related risk factors here? Well, we do know that people who use daily disposable lenses have only 1/12 of the risk of people who are reusing contact lenses with solutions. Daily disposables appear to be protective against CIEs. This is an important finding, and more recent data supports this. Robin Chalmers, who actually reported the previous data set, also in 2015 looked very carefully at over 1,000 wearers of daily disposables in a so-called registry study where hundreds and hundreds of people were fitted and followed extremely carefully for a 12-month period. In 2 different sorts of daily disposables, racking up over 1,000 wearer years worth of experience, a huge data set here. And they found that there were almost no cases of symptomatic CIEs in these daily disposable wearers. This lens type is remarkably protective against CIEs. And when we compare the incidence of CIEs altogether versus a range of other lens types, again, daily disposables win. Very good. A little bit of laboratory work that supports this. We've just published this, and I'm excited to share this with you. It's looking at the subclinical response. I mentioned before about these inflammatory cells, defensive cells that sit in the cornea. We were keen to measure how many of these there are with different sorts of contact lenses. And we fitted a group of subjects just for 1 week of contact lens wear. And when we followed them up, when we measured the number of these cells in the cornea, these inflammatory cells, we found that with daily disposable wear, it's almost no different than somebody who's not using contact lenses. And the amount of cells with reusable lenses is much higher. Again, there's something good about daily disposables as a protective lens type for avoiding an inflammatory response, either a subclinical sort of response, as I'm showing here, or a manifest response, a CIE, an infiltrative form of keratitis. So what do we know? Sleeping in lenses puts you more at risk of infection. Daily disposables are better for avoiding CIEs, particularly relevant, I think, at this time. But what other advice can we share with our patients? Graham Young in the UK did a great job a few years ago where he reported that if somebody's using solutions with their contact lenses, there are perhaps 49 steps that are required for fully compliant use. Well, nobody, I don't think, can be compliant with all of those, but some of these steps are more important than others. And I'm going to highlight today 8 steps which are modifiable behaviors. Each of these has been shown in the epidemiological literature to be associated with an increase in infection or inflammation. If patients are not doing any of these steps, then they are more likely to get an infection or inflammation. We did some work a few years ago and we found out of these steps, and you can see here how they are all associated with a greater risk of infection. We wanted to find out across a number of countries worldwide how compliant people are with these steps. So here are the 8 steps across the bottom here, across the x-axis. And this is the proportion of patients. There were over 4,000 patients answering this questionnaire. What proportion are fully compliant? Some things we're pretty good at. Look on the left there. Not wearing your lenses for excessive nights of overnight use, if that's your modality. Using the correct solution, relatively good. But over on the right-hand side, some things we're not very good at. And I'm going to particularly highlight these 3: hand washing, rubbing and rinsing, and case cleaning. These are, in effect, the 3 key steps of contact lens care. Why is this? Well, they meet the 3 criteria. 1, most patients don't do them very well. 2, they have been associated with an increased risk of infection. And number 3, there is evidence that patients can get better if trained. Now, you might be able to hear Happy Birthday playing quietly in the background. To wash your hands, of course, the latest advice is to sing Happy Birthday twice, 20-second hand wash. But these are the 3 key steps. Again, those 3 reasons, they're all associated with an increase of infection or inflammation if they're not done. 2, they're generally only done by a minority of contact lens wearers. And number 3, if we train and talk to our patients about all of these things, it's been shown they can get better. These, I think, are really important at the current time. And another video which you can find online, which I particularly liked, about how we should properly wash our hands, is shown here by this person who's put some ink on their gloved hands, and just shows how it's important to do the classic surgical hand wash, including rubbing between your fingers here. And think for a contact lens wearer, think of the importance of which bits of their hands are touching the lenses. Think of the fingertips and the tip of your thumb that's going to remove the blister perhaps from the contact lens, and remove the foil from the blister. And it's the fingertips that are touching the eyelids and applying the lens. These are the most important parts of the hand for our patients to wash. You can find that video online if you just search for hand washing with black ink or black paint. So where are we? How can we summarize the current remarkable, scary, incredible situation that we're all facing? And just about everybody around the world, perhaps based at home, although good to hear that in some parts of East Asia, maybe things starting to get back to some form of normality. Well, I think at the moment there is no evidence of an increase of infection in contact lens wearers. They're not more likely to get COVID-19 disease, and it does not seem likely that a contact lens is a vector for the virus to reach the eye and then to infect the body. That's the current information. Things could change. We need to keep a careful look on what we know and what's being published, so do watch out for that. Spectacle wear, well, spectacles sit on the face, they need to be washed, and probably they're not a good barrier to resist the virus getting to the eye. Our main concern at the moment then is we have patients at home who should not be leaving home. We have healthcare systems which are stretched. This means more than ever, we need our patients to be practicing safe contact lens care. So think about what the options are, what you would do if you had a patient who had a problem. Are you in a position to see them? If not, then who might you refer to, especially if you can keep them away from the healthcare systems that are going to be stretched and involved with COVID-19 cases. Think about those 3 key steps of contact lens compliance. All contact lens wearers need to wash their hands. They need to wash their hands and dry their hands as well before they apply lenses in the morning and take lenses out in the evening. We know that generally this is good advice against COVID-19 anyway. We all should be washing our hands, and part of the reason for that is that detergents, disinfectants, surfactants are good at killing the virus because of this lipid bilayer that it has. Some of our patients reuse lenses and they use solutions and cases. So the key steps for them is to rub and rinse lenses. We know this is probably quite effective at getting rid of viruses to some extent, more important than ever. This is an important step for getting rid of all microorganisms before the contact lens is exposed to the multi-purpose solution or the hydrogen peroxide, just to limit the bioburden that we are presenting to the active agent in the multi-purpose solution or to the hydrogen peroxide. If you're using solutions, you're also using a case, and there is fairly recent news on appropriate case care. A few things here. First, when the patient removes their contact lenses in the morning and applies them, they're going to have some solution left in their case. That solution needs to be discarded. They can't keep that and just sort of top it up in the evening. That's been shown to lead to much greater likelihood of infection because the remaining contact lens solution is spent, it is old, it is not as effective at killing the bug. So that needs to be discarded. So we're now left with a slightly wet contact lens case. Some of the work out of our colleagues from Wu and co-workers at the University of New South Wales report that the best thing to do is actually to dry the inside of a case with a tissue. The tissue itself gives a little bit of mechanical rubbing that just might remove any bioburden or biofilm that might be forming. So we now have a dry case. This should be left to air dry through the day, but not upright. The case should be put face downwards to dry, ideally on a tissue as well, so it can properly dry. That case really should not be left in a bathroom where there might be microorganisms floating around. It should be left somewhere else in the house. So they're really important anyway, but I think they're particularly important at this time. Some sort of contact lens wear, we know, does put the wearer at a greater risk of infection or inflammation. Should we be having a wholesale change? I would say no, but there might be some instances where it might be appropriate for patients to change the form of contact lens wear that they have. Some patients, for example, sort of move from daily wear to extended wear as they sort of, perhaps there's certain work days, they might sleep in the lenses, and at the weekend, maybe they don't sleep in the lenses. And at the moment, particularly if they're not working, well, if they're familiar with chopping and changing and making this alteration, maybe they should move to a daily wear modality. At least that's something I think you should think about, and maybe you've got some patients where you think that would be appropriate. In a similar sort of way, some patients have both reusable and daily disposables. They have reusable lenses maybe for their everyday life, and they keep a supply of daily disposables for holidays and that sort of thing. Well, maybe if they're familiar with use of both lens types and they have stocks of both, well, maybe now's a good time to be using their daily disposables, puts them at an optimized risk, a lower risk for getting a CIE. I would not be in favor of wholesale everybody changing. You know, people need to know how to handle lenses, how to use them appropriately. And many of us are not in a position at the moment to offer that advice. We're not in a position to look at the fit of a different lens type as we, different characteristics, design characteristics will fit differently. But perhaps in these sorts of patients, then it might be something that's worth considering. Overall, though, this is a fast-moving situation, and we all need to keep updated. We are clinical scientists when we fit contact lenses, and we need to respect that, and we need to keep in touch with all of the latest information. I wanted to finish this on a positive note because we live in such strange times. And I looked around for who said what recently, and you know what? I was pretty inspired by Queen Elizabeth here, our Queen in the UK. I'm not quite sure who writes her material, but he or she did a great job. Here are some thoughts to finish this presentation with Miloš. You know, we're facing this unprecedented time, and this one's a bit different. And it's, you know, we will all get together, all nations across the globe, to solve this through our advances in science and our instinctive compassion to heal. And we will succeed in this. There's probably a bit of this for us to get through. Certainly in most of the worlds, we're still enduring this, but you know, better days will return. We'll see all our friends again. We'll see all of our families and all of our colleagues again. We will meet again. So, final words from me. Stay safe. Things are different. Try and stay sane, and take care of yourself and your families. Miloš, I think that brings me to a close of my presentation.